year, left knee swelling since last 2 months, and fever since 1 month. Child was alright 1 year back when he developed loose stools, initially semi-solid, small in quantity, 5 to 6 times per day, greenish yellow, sticky in nature, and non-foul smelling, non-blood stain, associated with abdominal pain, relieved on passage of stools. Gradually, child started having stools mixed with blood. Consistency became more watery. Uh, and the child developed left knee joint swelling 2 months back, painless, non progressive, associated with morning stiffness in the form of limping movement, followed by gradual improvement on the range of movement over the day. For above complaints, child has taken symptomatic treatment on OPD basis and was admitted multiple times and received IV medications, but no improvement in symptoms. But child was active, feeding well, and passing urine adequately during the course of illness. Since last 1 month, child is having fever which is moderate to high grade, undocumented, intermittent, and occurring daily since 1 month. On inquiry, mother complains about the ulcers in the mouth since 10 days, 2 to 3 in numbers and painful. There is no history of vomiting or loss of appetite or any rashes, no history of any recent weight loss, no history of aggravating or relieving factors, no history of any involvement of other joints, no history of allergy, atopy, asthma, any family history for the same, no history of recurrent respiratory infections, skin infections, or ear discharge, no history of previous blood transfusion, no history of abdominal surgery, no history of any excessive intake of carbonated drinks, no history of blurring of vision, difficulty in night vision, no history of cracking of lips or over the angle of mouth, no history of any dry skin, scaling or peeling of the skin, no history of petechiae, ecchymosis, or easy bruising. ANC history wise, it was uneventful. Registered 3 ANC scans were done as per mother and told to be normal. No history of any chronic medical illness or ANC complications. Birth history wise, full term normal vaginal delivery, cried immediately after birth with a birth weight of 2.5 kg, no NICU stay, discharge on day of life 1, and the birth vaccine was taken. Immunized till date. Developmentally, he is appropriate for the age. Uh, Dietary history wise, he is taking 760 total kilocalories with a deficit of 340 kilocalories and total proteins 6 grams per day deficit.
Okay, so the first complaint is 1 year back. What is the age now? 1 year, 10 months. So 1 year back, that means at the age of 10 months, roughly, this child started with loose stools. So now what is your impression of that first paragraph? Whatever comes to your mind, start speaking, then we'll try and analyze it further.
At the time of weaning, maybe the child had loose stools.
So this is 10 months of age. So is that the normal time for weaning? So you need to ask, okay? Even otherwise, is weaning supposed to be associated with loose stools?
Improperly prepared food or hygiene.
So we have to be specific. So one is if there is poor hygiene leading to a proper infection, then the story will be that way. Okay, that is one. Anything else? Weaning related loose stools.
Allergies to food items.
Yeah, so celiac disease, food allergies, whatever, right? So here it is not weaning because it's at 10 months and probably they have not done weaning at 10 months. So what else? What does that episode suggest?
Till 6 months, he was breastfed, and after that, he was started on complementary feeding, but was predominantly on the milk-based diet. Yeah.
But little food was
Yes,
started.
yes, yes, sir.
Okay. So any other thoughts? So, I mean, as usual, what should we do? If you are going back in time by 1 year, and you are at 10 months in this child, and this child says develop loose stools initially semi-solid, what we have to first ask is, till that time, how was the child? So just before that, was the child bang normal? So you have to decide whether this was it is giving an impression of an acute episode or not, right? Then you have to decide whether it's an infection, no infection, all that. So what is first question is, what was the stooling prior to this? We have
Like,
asked or we
ye-
have not asked
yeah,
it?
yes, sir. The child was passing stools 2 to 3 times per day, but it wasn't watery. And we don't have any papers available for weight and height. But according to mother, the child was taking feed properly.
No, so what I mean is, I'm just teaching how to take history. So when this history that it was greenish, yellow, sticky in nature, whatever, whatever. My first question would be that 3-4 days back, it was not like this. Then you identify a change and then you decide, okay, what is happening. You go on further on that, right?
Yeah, I think nothing much to add really, but point that he's making is what was the child like prior to the onset? Was he healthy? Okay. If the mother says that she was healthy, the next question is, was there anything unusual that you feel has led to this? Then she would say, oh, we had gone out and ate something. Okay. Or we got something different. So you get an idea. So was there a change in the intake of food? Okay. When there is no fever, when there is no sickness, it looks to be simply an indigestion or a malabsorption. The first impression is this is an indigestion or a malabsorption. Okay. What's the difference between the two? Many times parents say, no, oh, I have an indigestion. What does that mean? What's the difference between indigestion, which is also referred to as a maldigestion, and a malabsorption? Any thought?
Duration of presentation. The duration of presentation of the illness that would lead us to understand whether it is maldigestion or malabsorption. Malabsorption is a more chronic or repetitive process if the same food is introduced in the child's diet recurrently.
How does the clinician differentiate maldigestion from malabsorption? And if you cannot digest, you cannot absorb. So maldigestion also and malabsorption lead to same problems. And therefore, a malabsorption is largely small intestinal. Okay. And therefore, there is a frequency of stools. A maldigestion may not have. Which are the organs which digest food? Is it intestines? No. Intestine get a digested food.
Starts with the salivary amylase or ptyalin in the buccal mucosa, and then it goes on to the stomach, then to the duodenal part, and then the entire small intestine. The excreta comes around when the excretion products come around the large intestine. So the process starts from the mouth itself.
Very good. So saliva, then stomach, then pancreas, then liver, then bile system, all that decides how they should digest food. And what does digestion mean? Very good. Breaking down into micromolecules, which alone can be absorbed by the intestine. If digestion doesn't occur, the larger molecules get through intestine and cause allergic responses. They're not supposed to go like that. Okay. And therefore, this suggests that there is probably a primary intestinal disorder, little frequent, 5-6 times a day. Okay. Then it says that greenish. What does greenish mean?
Containing bile. So that's normal or abnormal?
Bile has to be there. No, for digestion, what is so great? If there is no bile, there is no greenish stool.
The child is not taking well orally or child child is having frequent loose stools, then the turnover, the let down response will be there. The transit from stomach to intestine will be there.
So I think the biliary system doesn't know that there is not going to be food. And therefore the bile comes in and there is no food to digest. So the bile is thrown out. So starvation, you are talking about that. Okay. Is this child starving? Well, any illness makes you starve. And that's why it's not greenish, yellowish, green. So we don't give any thing to that. So the question is, this is malabsorption. Now, malabsorptions are of two types, non-inflammatory and inflammatory. What is the difference for a clinician? Any thought?
So symptoms like abdominal pain, cramping abdominal pain will be in case of inflammation. Non-inflammatory will not be like, or like other signs, fever, etc. in case of inflammatory.
So what is an example of non-inflammatory malabsorption? Then you'll understand the difference. Which malabsorption is non-inflammatory? Some congenital absence of an enzyme or something like that.
Channelopathies.
So
Viral diarrhea, the parents say that there is an excoriation of the anal region. There is a lot of gas. So there is a lactose intolerance. Is that the same as what he's saying? Congenital enzyme? Then it's acquired enzyme deficiency. What is acquired?
Course of the illness, secondary loss of the epithelial cells that produce the enzymes.
Correct. So the answer is, in the intestinal mucosa, the most superficial layer of the mucosa holds a lactase. And therefore, any mucosal disease, the lactase gets away and you start getting acquired lactose intolerance, which doesn't need treatment, and illness gets over, the mucosal enzymes comes back, and therefore this is very common that a viral infection disappears in 2-3 days, but the diarrhea may continue even for 2 weeks. But it's not a malnourishing diarrhea. Baby has normal. So that's that. Okay, it could be a fatty malabsorption, large stools, foul smelling, less frequent, okay, or carbohydrate. Then what is an inflammatory malabsorption? Painful? There is some pain, but pain is relieved after close, so it must be a gaseous distension. So what is inflammatory? There is no fever. So which is this non-inflammatory, non-febrile illness?
So does inflammation give rise to any other clinical symptoms besides fever? Pain. So we talked of pain. Anything else? No, that is you're talking specifically of GI inflammation. We're talking of in general.
So the point is, acute inflammation has all that. Fever, pain, redness, whatever. So this looks like a chronic inflammation. But why do you call it inflammation? One, because there is no typical carbohydrate malabsorption, no typical uh, fat malabsorption. Therefore, it's likely to be non-inflammatory. And what's the characteristic? A general constitutional symptoms. I'm not feeling well. I have a loss of appetite. Malabsorption, people eat a lot and still pass through and still lose weight. So if you have a fat malabsorption or a sugar malabsorption, you eat well and you pass. But when you have an inflammatory malabsorption, you don't have appetite. That's why the greenish stool. So greenish stool means this child has an immunological. So obviously inflammatory malabsorption. What is inflammatory malabsorption? It is chronic. So it's going on for some time, but the person doesn't know. How is it going on? Not eating well, losing weight. Okay. And then comes the next blood, which is 100% inflammatory, right? Now the question is what inflammatory? The moment you do that, the first paragraph gives you a full diagnosis. Well, we can fine tune it.
Inflammation is in which part of the body? Anatomy? GI tract. Where in the GI tract? Esophagus, stomach, intestines. So inflammation is in the intestine. So you have
Small
a
or large?
Yeah, so it will also depend on what is the nutritional status of the child. So if it is small intestinal inflammation, there'll be a problem in absorbing nutrients, so nutrition will suffer. So later we have heard that he is undernourished and his diet is less and all that. So we are 50-50 on that, whether it's small or large alone, but it could well be small as well, right, at this point.
Here is a small plus.
Okay. Now, sir.
Yeah. In the beginning, it may be the same, right? In the beginning, loose motions, abdominal pain. The history suggests that mucoid stools with lot of perhaps tenesmus, which suggests more of a large intestinal disease than a small intestine. In the beginning, it may be difficult to decide whether it is actually an inflammation related to infection or it is non-infective. But over a period of time, when the things continue the same thing, or maybe you'll do a routine stool examination, which doesn't help you to make a diagnosis, and the patient continues to have the same thing, probably an infective cause is ruled out. And then we come to inflammation. The loss of appetite, loss of weight, etc., may take a little longer time, but perhaps pain in the abdomen is an important thing. Inflammatory intestinal disease without significant abdominal pain usually should not happen. And therefore, if the child is irritable from time to time, not only while passing stool, but most of the time cries, that's not something which often will occur only with malabsorption, but more with inflammation. Loss of appetite, etc., will take time. Then, as the child passes blood in the stool, you think more of a large intestinal disease, and you have 2, 3 conditions which are related to that. Fever, if it is present, it helps. Absence of fever may not help, but we are probably right in the beginning thinking of something. First thing is infection, non-infective, probably inflammatory, less likely to be malabsorption type of. Malabsorptions are usually large, watery, so small intestinal disease, large, watery, without much affection of, of appetite. Appetite is maintained. Child also will be relatively okay. Appetite is good. Here, the child going to be sick over a period of time.
To me, it looks like a chronic amoebiasis. Chronic, inflammatory. Okay, blood and mucus. What inflammatory disease? Chronic amoebiasis. Yeah, giardia largely much less stool, blood, more of malabsorption, fatty stool, but chronic amoebiasis.
Arguments against no
Chronic,
fever.
chronic. We have used the word because there is no fever. Okay, yeah. Keep one mic there. Only.
Over time, child will become more sick if it is chronic amoebiasis. And other features like abscess, like liver abscess, etc., like other extraintestinal features can come if like it's present for such a long duration.
So chronic, have you seen amoebiasis in children?
Chronic.
Amoebiasis, then where? Western world. And therefore, what you mean is that acute amoebiasis is extremely rare in children Chronic amoebiasis takes a long time to manifest, and many children keep on coming again and again. Okay. And therefore, generally, amoebiasis is less diagnosed in pediatric practice. Not that it cannot occur, yes, and therefore, largely, bacterial viral infection predominates so much more often that you have really nothing else. In general, the rule of the body is if there is an infection in one part of the body, the other infection will not come. It's almost like if you're coming late in the night and a dog comes after you, but moment you leave that lane, he doesn't come behind you, then another one takes care. So each organ, like an each dog, has its own premises to start. Rarely you have bacterial plus viral. Okay. And therefore, amoebiasis is really rare. Watery stool to begin with, changing, all that doesn't happen. Amoebiasis. Frequency is not often the thing, but only one or two stool, but abnormal stool. So just to bring a point that this is non-infective, right? Then what is it?
Okay, now come to the joint. So,
Reactive arthritis can happen, sir, in GI inflammation.
so but now go deeper. So when classically, when have you seen reactive arthritis? Following which infection? Or
Urethritis,
so
uveitis.
GI, GU, rest, whatever. Now the first thing is that first episode is not an infection we discussed for last half an hour. Second is look at the joint. So painless, non-progressive associated with morning stiffness. Now, what I want is I want all of you to keep thinking. So what does that suggest to you? Painless, non-progressive and associated with morning stiffness and limping.
Morning stiffness indicates inflammatory thing.
What type of inflammation? So inflammatory means as in you differentiate it as inflammatory against mechanical. So that is morning stiffness. Now, why is this child limping? Is he limping out of stiffness?
Pain, but non-pain.
So that is what I want you to be awake to. That it seems a little contradictory that it is painless and yet the child is limping. And it is very unlikely to be painless. Even the morning stiffness of rheumatoid arthritis is painful. So therefore, painless is like little questionable. Okay. Now, so you were saying reactive arthritis. So again, typically, what is the story of a reactive arthritis? Large joint or small joint?
Large joint.
Large joint. Swelling or no swelling?
So swelling is there.
Swelling, pain, and large joint, and then splitting from one joint to another, moving from one joint to another.
Is there a single one at a time?
One at a time, but multiple.
Multiple.
Finally, yeah. So this is what only one knee joint swelling. Okay.
That brings another differential diagnosis. And this is tuberculosis. Single joint, not multiple. Intestinal tuberculosis, now not treated, not picked up, disseminating. It's tuberculosis. Single joint is infection. It's not acute septic arthritis. Okay, which other infection? Single joint, tuberculosis. Non-infective, hemophilia, trauma. No, no question. Tuberculosis. It fits in properly. Chronic inflammation, intestine, thereafter joint. Okay. Small young child might do a CSF, might have started meningitis as well. You don't have to wait for a seizure to come. We have waited for a joint to come.
So to answer sir's question, go back again, cut the joint and look at only the intestinal story. Does that story fit into intestinal tuberculosis? In the last half an hour, did we discuss tuberculosis as a DD? Why not? Why doesn't it fit into tuberculosis? You're right, it doesn't fit, but why? That we'll have to dig.
Stone sequelae are like additions and any.
So what is the textbook picture of intestinal tuberculosis? It manifests as
Peritonitis.
intestinal. We're not talking of peritoneal TB.
Stricture. Yes.
Ileocecal involvement should be there.
Is the anatomy, clinical manifestations,
Constipation.
subacute intestinal obstruction. Your first word which came from your mouth was constipation, and this patient has come for diarrhea, right? So that first picture is not fitting into tuberculosis. So that subsequent thing is
And tuberculosis is intestine, but which part of the intestine? Not mucosa. Sub- Therefore, diarrhea is not a common feature, but submucosal inflammation. So the body tries to restrict the inflammation. Scarring occurs, fibrosis occurs, and then you have an intestinal obstruction, which is subacute, comes and goes, and because of constipation, there is some overlay of diarrhea also. Therefore, the Nelson says alternating diarrhea and constipation. It doesn't mean Monday diarrhea, Tuesday constipation. So it's constipation mainly. And the reason, mucosal. Okay. And therefore, this cannot be. Other thing is, how does the tuberculosis disseminate everywhere?
Fatigue.
Okay. And therefore, common entry is largely the lungs. And then the common organs involved are not the joint, but mainly the brain. Okay. And therefore, how does the allow this bacteria to select an organ?
The blood supply of the organ.
Blood supply, every organ has a blood supply. So, moment you see a young child, oh, meningitis, you have read. Okay. And therefore, the point is that there has to be some vulnerability. Okay. If I have been playing a lot and getting hurt everywhere, it's likely I may get that. In fact, author has said that intracranial infection is always a susceptible host because it's a well guarded organ, and you can't have a thief going into a president's or a prime minister's residence. That's not possible. And therefore, the point that I'm making is I just want you to understand many issues which are not likely, but that gives you an idea how each issue is a bit different. So we come back to now. The point is, if you thought this was an inflammatory bowel disease, then be sure it is likely to show you some mouth ulcers, some eye problem, some joint problem, skin rash, straight away at that time. And you could have asked or you could have counseled, ये सब हो सकता है. Okay. But is that the only inflammatory disorder? Can it be a celiac disease? Celiac is an inflammatory disorder, intestinal disorder. What about celiac?
Will aggravate to the gluten containing food item.
okay, that is one. What else?
Skin rash. Associated.
Skin rash. So skin rash is not like a make or break, no? Whether it is there or not there, it won't make or break your diagnosis. But typically, it should start with the weaning, though of course there can be different severities, so it can start a little later also. But what about blood in stool? Blood in stool is very uncommon in celiac, right? So that is why this is more of a inflammatory bowel disease rather than a celiac disease. And then that is the extraintestinal manifestation as arthritis. Then you have fever also. Last 1 month child is having fever. Okay. What do you think of this fever? Quick. In general, what are your thoughts for any fever? If it is an infection, it should have localized. So it should have given symptoms pertaining to that infection, which it hasn't in 1 month. This is again more likely to be inflammatory fever only, right? So your story is almost fully built up for a inflammatory bowel disease with extra-intestinal manifestations with systemic inflammation, right? Sure. The patient is here. Okay. And mouth ulcers, which, yes, just tell us your differentials.
The inflammatory bowel disease, the first one, the autoimmune enteropathy, and the multiple food protein allergies.
So why autoimmune enteropathy?
There's a joint involvement also. It could be. There's also.
Means I'm not sure of this terminology. Is it a separate disease? I'm not sure. The whole process is autoimmune, no? Okay, anyway, multiple food protein allergy.
Yeah.
Why? Points for, points against.
Against for they have tried stopping milk or stopping particular food products, but it didn't help. So it could be multiple food protein allergies. But against there should not be any extra intestinal manifestation, which is there.
Okay,
So,
and
an immunodeficiency.
Will that occur in protein
Okay.
allergy?
No.
Points for and against immunodeficiency.
Uh, there must be multiple admissions for other infections like respiratory or any UTI infections. But
Which are
there
not
wasn't.
there.
No, only admissions are there for the loose stools only.
And where also he has not responded.
No, sir.
So they are not infections only. That's why he has not responded. There's no question of immunodeficiency, right? Okay.
Immune deficiency and inflammatory bowel go together? One is deficient immune system, another is hyperactive immune system. That means I am dull, but I got a gold medal.
Presenting in
Too
infants.
extreme, no?
So IgA, immunoglobulin A is the mucosal immunoglobulin. So if there is selective IgA deficiency, then the GIT protection won't be there. So inflammation can happen.
What sir is saying is basically what is inflammatory bowel disease? What triggers that inflammation? Or who means who the body is fighting against its own intestine, so it's kind of autoimmune. So it's a angry immune system or a over powerful immune system. So sir is pointing out that and immunodeficiency are two opposites.
And the answer is yes. Answer is yes. Though what it means is immune system is not behaving. It almost looks like deficient sometimes. It might so it is a dysregulated immune system. Okay. And there three things are important in immune system. One, it could be deficiency, presentation. It could be hyperactive inflammation, like what we are discussing, or it could be malignancy. And therefore, an HIV can come with Burkitt's lymphoma, which is a malignancy. Both are dysregulated. One is almost not working, another is unnecessarily working too much. And that is how all three characteristics of immune problems meet each other, right?
On examination, the child was afebrile with a heart rate of 88 per minute with a respiratory rate of 24 per minute, maintaining saturation on room air. Peripheral pulse is well felt, extremities warm. BP between 50 to 90 centile, normal HGT with a pallor present, and bilateral subcentromedic lymphadenopathy cervical lymphadenopathy is present. No cyanosis or icterus. Anthropometry wise, there's a severe acute on chronic malnutrition with weight less than -3 standard deviation, length less than around -3 to -2 standard deviation, and weight for height less than -3 standard deviation.
This child, just go back. When did the illness start in this child? Can you guess when was the origin of the disease? Story is only for 2 months.
Standard.
Yeah, long standing, but we've taught you this earlier, na? Looking at the height, you can judge when the illness started. Isn't it? You have to be more specific. When in infancy? First half or second half? Why second half? So 1 year, 10 months, what should have been the height? Normally
85, 87.
85. So 85 has become 80. So it wouldn't have just stopped at 80. That means it started slowing down much earlier, right? If it was in the first half, what would be the impact? No, in height, what would be the impact? Less than? So it would be much more affected. It wouldn't be 80. So that is why second half of first year. Yeah.
On a head-to-toe examination, head size and shape is normal. Hairs are thin, lusterless, and easily pluckable. Eyes and ear are normal. Oral cavity ulcers are present, tainted with erythematous base. Poor oral hygiene is there, and chest, spine, and abdomen is normal. Genitals are normal, and there is a perianal rash present. There is an extensive excoriation. On local examination, left knee swelling is present, non-tender, no redness or edema present, and no restriction of range of movement. Systemic examination, on inspection, abdomen is flat, umbilicus central and inverted, no visible veins. And on palpation, there is no tenderness or guarding or rigidity, no organomegaly present. And on percussion, tympanic note is heard. And on auscultation, bowel sounds are heard. So, 2-year-old boy is a case of chronic inflammatory mixed type of diarrhea with left knee monoarthritis, with anemia, with failure to thrive in a birth and developmentally normal child, fully immunized, with no significant past history in the family, is a case of inflammatory bowel disease.
Really a typical enteropathy word is used almost when there is a significant malabsorption of all types. For example, a differential diagnosis of nephrotic syndrome might be an enteropathy. That means everything is washed out, including proteins, carbohydrates, fats, etc., which is the term used only for that. Otherwise, as he said, even inflammatory bowel is autoimmune and it's also enteropathy. What is enteropathy? Pathological entero, so intestine. So typically, when you see nephrotic syndrome with diarrhea, you could entertain that. But many nephrotics have diarrhea. Then how do you differentiate the two? You get the question? Protein losing enteropathy, that's the word. Okay. And here protein losing urinary. Both look alike, massive edema, etc. Okay. But nephrotic may have also diarrhea. Why should nephrotic have a diarrhea?
Not in SBP, even otherwise. In gut wall edema. Okay.
And therefore not too many loose stool. Enteropathy, a large number of stool. And this is not, because that enteropathy, like nephrotic syndrome, is not having blood. Does nephrotic syndrome has hematuria? No.
So usually no, but sometimes, yeah.
These are the investigations. CBC showing a WC count of 15,000 with HB of 7.4 with platelet counts of 8,28,000. And on LFT, total BLE of 0.4 with normal OTPT and total protein 5.9 with albumin of 3.3. And on stool routine microscopy report, there's occult blood present with a burst cells of 80 to 100. Cox workup is negative and TTG is 0.8 and IgG is normal. USG is also normal. The colonoscopy was done showing ileum mucosa is normal with IC valve normal. Pancolitis with left-sided more involved than right and multiple aphthous ulcers, deep longitudinal ulcers seen with cobblestone appearance. Angioscopy was also done, which was normal.
Fine. How will you treat this child?
We'll start with corticosteroids first. We'll see the response to the corticosteroids, and then we'll start with sulfasalazine or amino salicylic acid drugs. And immunomodulators can also be tried. And also nutritionally also we support it. And we'll repeat colonoscopy for the prognostic point of view. Like if it is responding or not, we'll repeat it.
We'll have the
Okay,
second.
only other condition the GI people talk of is eosinophilic gastroenteritis. There is no difference clinically at all because basically it's an inflammatory bowel only. But when we talk about inflammatory bowel in pediatric practice, it's generally Crohn's. Okay, in adults, it may be not Crohn's, but more of a ileal problem. And therefore, in children, right from duodenum up to the large intestine, multiple ulcers. And to that extent, eosinophilic gastroenteritis is a histopathological diagnosis. I don't think clinician can differentiate it at all.
The CBC is also typically most of the autoimmune diseases. Very high count without obvious infection. Platelets have gone sky high. And if you're not, I mean, you're not mentioned, neutrophils will be high. So apparently it looks like an infection, a bacterial infection. Obviously, clinically, there is no bacterial infection. So high count and high platelets are good markers to look at for inflammation. You see anything, juvenile rheumatoid, other disorders also. High count, high platelets. So this is what is here. Can we call this ulcerative colitis? I would still think of like an ulcerative colitis, even if there is no ileocecal, because largely colonic involvement, ulcers, multiple ulcers, and bleeding. I would still think because I think two most important diseases are one is the Crohn's and second is ulcerative colitis. So to fit in with one of them, so probably ulcerative colitis at this stage. What do you think, sir? We had seen one child, doctor's child, came initially for blood and mucus in stool, treated as stool showed multiple pus cells, initially treated as bacillary dysentery, went home, came in 1 week or so, with blood means just flowing blood on the commode, and it was not like a bacillary dysentery. Obviously, a diagnosis of ulcerative colitis was suspected, was proved. That lady mother was a doctor who had just migrated from USA to India to settle down here. And because there was ulcerative colitis, they all went back. Just blood. Lot of pain, maybe mimicking superficially bacillary, but obviously the history is not like this.
Rajesh, can you hear us?
Sorry?
We cannot see the faculty.
Good evening, everyone. A 10-year-old girl, forced by birth order, born out of non-consanguineous marriage, hailing and residing from Jabalpur, Madhya Pradesh, Hindu by religion, Sahu by caste, brought by and informed by father with the complaint of weakness in the lower limbs since 2 years. The child was all right 2 years back, after which child had complaint of weakness in both the lower limbs, which was insidious in onset. Initially, the child was able to walk. However, parents noticed that the child used to fall during walking. Uh, After that, the child required support for walking. Child was able to get up from supine and sitting position and was able to squat initially. However, over the course of next 6 to 7 months, she had difficulty in getting up from sitting position. She would stand up from the sitting position by taking support from the ground with the help of her hands. She was able to roll onto side without support. There was no history of slippage of slippers. She was able to feed herself, comb her hair, and wear clothes. The weakness gradually progressed over the last 3 months, where she is not able to get up from sitting position on her own. At present, she is unable to roll over without support. The child also had complaint of swelling of both the calf muscles, which was non-tender, symmetric, and gradually progressive. Since the last 3 months, parents also have noticed change in the posture of the child with apparent protrusion of the abdomen and change in her gait as well. No history of abnormal sensations or loss of sensation. No history suggestive of any cranial nerve involvement. No history of abnormal movements. No history of bowel or bladder involvement. No history of flushing, sweating, or dizziness. No history of similar complaints in the family. No history of ptosis, diurnal variation of weakness. No history of repeated exacerbations. No history of any feeding difficulty. No history of breathlessness or chest pain. No history of thyroid disorder in the family. No history of fever and vomiting. No history of rash over the face. No history of drug intake and no history of contractures. Birth history, it was a full-term normal vaginal delivery. Baby cried immediately after birth. Birth weight of more than 2.5 kg. No history of neonatal jaundice or an ICU stay. Immunization-wise, the child is immunized up to date. Developmentally age-appropriate milestones were achieved. Dietary history, the child consumes mixed diet from the family pot. Socioeconomic-wise, the child has an younger sibling who is 4 years old, who's a boy, who's normal. The child belongs to a lower middle class family.
So where is the anatomy of the weakness?
What do you exactly mean by weakness? What did the parents say? Weakness means what?
Initially, the child was not able to walk properly. She was falling during walking.
So it started as frequent falls while the child is
Yeah.
walking.
The peripheral nervous system. So there are no central signs. So over the entire course, the child has been all right, no convulsion, higher mental functions were all right, no affection of the higher mental functions.
Need not be, no? If it is one-sided central, you will not have all that.
In nature.
So the weakness is bilateral, so it has to be, if it is central, it has to be bilateral, so it is not central. So peripheral. Peripheral upper motor neuron or lower motor neuron? Why lower motor neuron?
Their other upper motor neuron.
So science, though, we have to still examine. But typically, upper motor neuron will come with change in tone, whereas lower motor neuron will come in change in power. So this is weakness as per the history, gradually progressive. So lower motor neuron. Where in the lower motor neuron? What are the different parts and where can you localize? So
So different parts are anterior cell or nerve, neuromuscular junction, and muscle. It seems more like in the muscle.
why?
So anterior horn cell, there'll be absolutely no power. The child.
Not necessary. No power. It can be slowly progressive. No, so significant weakness should be there in anterior horn cell, which it is. She's now not able to sit and get up from sitting position. There's significant weakness. So do we know of any anterior horn cell disease which goes on like this for 2-3 years?
No.
What no? Of course there's a disease.
Polio.
Polio. For 2-3 years it will go on.
SMA.
SMA. So
Age of presentation goes up.
If we are suspecting SMA, so we should be seeing diurnal variation of presentation. Also, tongue fasciculations and all should be documented.
So diurnal variation is a
Neuron.
feature of SMA or of
Neuromuscular junction.
NM junction, not of SMA. And tongue fasciculation will be on examination. Okay.
In SMA, there will be wasting.
Which will come on examination. So, yeah, type 3 is late. No, so how late you don't know. So I'm not very sure whether at this stage you can throw out SMA. Come to the next nerve.
More distal weakness will be there.
Okay, more distal and
Length dependent weakness. And now
nerve is length dependent weakness. How long is the nerve and all. And what else? Sensation, no?
Peripheral.
Sensory disturbances. She's a 10-year-old girl. So some sensory disturbances should have been there. Okay. So less likely. NM junction variation and muscle possible. So you are between anterior horn cell and muscle as far as now on history.
I think this brings us a discussion that lately I think it's a fashion to have lot many negative points for a one or two symptoms positive. Okay. And why do we do that? When we were trained, we were told negative history relates to two things. What parents may forget to say. Okay. Because it's such a small thing, no? Why talk about it to the doctor? I'm worried about fever. So something of that kind. And the second is, do you anticipate such negative history? Okay. Now, if you go through the negative history, there is no need of asking anything at all. The only negative point you should have asked is, first, is there anything related to the center? And what he said, tone. How will you ask the history whether it's a increased tone or a decreased tone? Okay, that's the differential point. You could have said there is no history suggestive of hypertonia or hypotonia. That is important, no history. Because parents won't say, okay. The rest is not that. It's important to say no history of headache, because I'm worried about whether this sign is, for example, a typical slowly developing hydrocephalus can present exactly with bilateral lower limb signs. Okay, but it's a spasticity. So tone is more affected than power, and therefore bilateral upper motor neuron in the brain, yes. What about spine? A condition called a spastic paraplegia starts at that age and goes on worsening. The child becomes wheelchair. It's a progressive disorder. Only spastic paraplegia, no bladder, bowel, etc. There could be a spinal cord tumor, 2-year story, extradural tumor, but there would be sensory, bowel, bladder, etc. So what you could have said in the negative history is no history of headache, no history suggestive of change in tone. What kind of change in tone you would have got from the mother to tell you? Spastic or hypotonic?
By lifting, if the child, while wearing slippers, if slippers slip out of the feet, then that is distal muscle weakness. Peripheral neuropathy.
If you had asked for the tone, is the baby lying like this? Okay. Or is he crossing the legs? The mother would have said in this child, one of the two. Tone is normal. That small change in tone you can find out on examination, but not that. And that is because the muscle is involved. That's typical. Had it been anterior onset, it would have been all flopping. Same thing to some extent, nerve, besides, of course, nerve may have a sensory problem as well. But a muscle problem, the tone is not much different. For a mother, tone is normal. So you could have got that negative history. The rest of the negative history is not important. How will you forget? No history of long fever. Mother will forget to tell you that there was fever. No. So I think pick up that. Now, I don't know whether present examiners want a long negative history. I'm not sure. But I would say that's not clinical medicine. Long negative history has no meaning, which means, oh, this is not brain disease, this is not heart disease, this is not liver disease. No. So possibly, if you had asked those things, you would have come up to muscle straight. Now the question is it myopathy or muscular dystrophy? Both are muscle disorders. Both are chronic. And of course, dystrophy is also part of myopathy only. But there is something different. So what's the difference between typical myopathy and muscular dystrophy? Myopathy is pathological muscle. Dystrophy is also pathological muscle, but the term indicates something different. What is that difference?
Storage of material inside the muscle seen in dystrophy.
I'll have to wait for enough storage to make the bulk of the muscle. I'm not going to wait till then. I want to start right from day one. Difference between myopathy and that.
Facial involvement. Myopathy can have facial involvement.
Okay. Myopathy is static. Dystrophy is progressive. Okay. That's that's the major difference. Then thereafter, the rest of the differences can go on with this. So there's obviously a progressive. So this is not a myopathy. This is a dystrophy. And dystrophy then would be having either a localized dystrophy or a generalized dystrophy. And to that extent, then you start saying whether it's Baker's coming up a little late or a typical Duchenne, right?
But girl child, no? So you should talk of Duchenne's? Hmm?
Dystrophy is atrophy with regeneration taking place simultaneously. At one place there is degeneration, another place there is there is regeneration, effort at regeneration, something like cirrhosis, regeneration. But that regeneration is problematic in cirrhosis. Here also it may give rise to so-called pseudo-hypertrophy because of regeneration. The regenerated cells are not useful cells. Okay, so that is why that's the difference between dystrophy and uh, atrophy. Now, the other question was, yes, where were we now?
Girl child.
Yeah, girl child.
Ionization, like inactivation of the X chromosome. Then, so inactivation of the X chromosome.
आगे
one of the
बोलना,
X
डिटेल में बोलना है ऐसा. Just don't throw words.
So inactivation of one of the X chromosomes in females.
Is it normal or abnormal?
No.
Is lionization a normal phenomenon or an abnormal phenomenon? It's normal.
Normal.
So then how does it make Duchenne's possible?
Normal X chromosome has been lionized and the disease X chromosome can be
Very good. And you have to complete that. So is lionization an all or none phenomenon? Means what I'm trying, for understanding sake, I'm explaining. You have two X chromosomes. So imagine you call them number 1 and number 2. So in 100% of the body cells, it is not that either one will be leonized or two will be leonized. Somewhere one is leonized, somewhere two is leonized. So if it so happens that your normal X chromosome or your abnormal X chromosome is the one which is leonized in more than 50% cells, then you will have this situation where even a girl child will show as Duchenne's, right? So that ratio is important of how many cells have been lionized that way.
Well-known entity when it occurs, X-linked muscular dystrophy. This is X-linked for the reason that uncommon, but when everything is there and only a presence of female sex deters you from making a diagnosis of Duchenne, which it should deter you, and you should think of an alternative diagnosis unless you are compelled to make this diagnosis, because this X-linked variety of muscular dystrophy is uncommon. And therefore, before you make a diagnosis of uncommon, you should be sure about it. And the first thing we were talking about as a DD, yes, we were talking about SMA. Why not SMA? Weakness all the way, progressive weakness. Fasciculations, who knows, unless you see that. And hypertrophy, pseudo hypertrophy, you will see, parents may not see. There may be proximal more than distal, okay, agreed, but maybe only on examination. Maybe atrophy, muscular atrophy and weakness is any anterior spinal cord disease, anterior horn cell disease, atrophy is a very marked feature, like in polio also. So in the SME, I would have expected by now the muscles have shriveled, become so thin now, apart from loss of power. And of course, it might have spread by now to upper limbs and cranial nerves, and you will see the fasciculations, etc. But atrophy is a hallmark of anterior horn cell, weakness and atrophy, like we used to see in polio, and we do see in SMA.
Okay, and then you have the swelling of the calf muscles, and then you have last 3 months change in posture. Why is that? So this change in posture is while sitting or standing or walking. But she is now not able to walk, no? With support. So why is this change in posture?
lumbar lordosis is
Very good. Why?
weakness of the pair.
So one is weakness of the muscles, but more importantly,
The weakness and to maintain the center of gravity.
very good. Very good. Yeah. So that is why there is lumbar lordosis, and that is why there's abdominal distension.
The hips, okay, which are responsible for maintaining posture. So since it is not there, there is a tendency to give room. So you do that. That happens in obese also. That is why there is lordosis.
What are the other differentials? If it is one knows Duchenne's, we said. Any other situation where you can get Duchenne's? Besides the lionization Turner and any other differentials? Very good. So autosomal recessive muscular dystrophies, there are, which will come even in a girl, right?
A 9-year, 11-month
Why
old,
not myositis?
no pain, no pain.
Yes, very good.
9-year,
Tenderness and pain.
9-year, 11-month old girl with a complaint of gradually progressive muscular weakness with proximal more than distal, lower limbs more than upper limbs, with no sensory involvement and no history of bowel or bladder involvement, with preserved sensorium, with no cranial nerve involvement, with no significant family history and normal birth and development, is a case of muscular dystrophy to rule out Duchenne's muscular dystrophy and Becker's muscular dystrophy.
Why did it present with frequent falls as the initial manifestations? Anybody? They typically present as frequent falls. Which muscles are weak in the beginning? Before that. Vortices may give rise to waddling gait. The extensor, dorsiflexors of the legs are the first to go. So there is a partial foot drop. And when you walk, you are supposed to touch your heel first and not toe first. When there is a partial foot drop, the toe touches the ground first. And if your toe touches the ground, you will have it. That is why there. So when he walk, if he is there and if he walks, we will see that his toes will touch the ground first. If you the HR cover. आपका नाम बोलो और जोर से बोलो. Very good.
Child is in sitting position. Child is in sitting position. There is hypertrophy of there is pedal edema present.
I'm not very sure whether we'll call it pedal edema on inspection. Okay.
Yeah.
You'll have to check whether,
Fitting.
yeah. Second, Yeah, sir, त्यांना बोलू द्या. So what happened to arching of soul?
There is dorsiflexion of the lower limb. Because of that, she was walking on the toe. So that's why she's forming that arch. Also, there is a contracture in the.
Then, chalo, everyone who wants to speak. Calf muscle hypertrophy. So on inspection, you will say it is prominent. Okay. Or okay, you may say hypertrophy. Then anything else? If you want good observation from all of you. First thing you would have said is she's on a wheelchair, which means that she's not ambulant. Second, go on now. So calf muscle hypertrophy. What else?
Inside the mouth. Under the core. No tongue fasciculation.
लोग सब रजनीकांत है. जा एक सेकंड देख के no fasciculation. You need at least 60 seconds to see carefully to make out whether they have fasciculations or not. Then observe. Kare sir was making some point. I told him, wait, let them come out. So in both upper and lower limbs, if you are saying this is hypertrophied, this is wasted in comparison to that. See, there's no, normally this is your biggest muscle, quadriceps. So there's no bulge of the quadriceps here. So this is waist. Similarly, you can see this is nice like an athlete, but compared to this is wasted.
Without even rolling the sleeve, you can see that this should have been much, for this to be so much prominent, this should have been much more muscular.
This is what you have to pick up and talk in the exam. Okay. Now, so Pankaj, tone.
Rajesh, we cannot hear you.
Yeah, we are examining the girl, so there's
Okay.
no continuous speaking.
Yeah. Okay.
Yeah.
And
Today
also
we
we can't,
couldn't,
there's no video to see the
yeah, today we
patient.
couldn't manage a
No
video.
problem.
There was no second device.
Okay.
So you are expecting muscles or you're jerks or you're not expecting jerks? there any family history in this? No. She has brothers.
4-year-old younger brother. No man.
Should you remove that or should you not remove that? Why not? So it will cause pain, which will cause, what reflex will it give you? Withdrawal reflex. So not this. Why have we learned this adult thick soul? That is why we have learned all wrong things. So don't continue in pediatrics. Okay? Okay. Now, demonstrate pseudo hypertrophy. Why are you frowning? You said, no, this is hypertrophy. So prove that it is pseudo. How will you prove?
Power has not increased with respect to the hypertrophy.
You will check for the power at the ankle and you will show that it is in fact a shade 4 rather than 5 plus. And therefore that is the proof that this is pseudo. Okay? Fine. चल सकती है? पकड़ के चलती है क्या ऐसे ही? ठीक. एक बार खड़ा करके चलाएंगे. इधर ही खड़ा करो. तो चेयर को पीछे ले. Move.
Toe touching the ground first.
पकड़ना उसको. Okay. Very good, beta. बैठ जा. So why do you get waddling? So finished. Anything else? No.
Indian doctor whose sign is seen here. Huh? Value sign. So do you want to see that? See that. Doctor, get his name.
Pradhan. So why do you get waddling? What is waddling?
Weakness of hip abductors lead to tilting of the hip.
So waddling is tilting of the hip with each step to that side and then the opposite side.
And
That is
compensate trunk will move to others.
yeah. So now tell us why it happens in these children with Duchenne's. So what happens in normal walking? What is Trendelenburg sign? And then why all this happens? So in normal walking, sir just said that when you strike the foot, you put heel first. So in the normal gait, there is a phase when your one foot is on the ground and your second foot is off the ground. It is in the swing phase. So at that time, what is supposed to happen is gravity is supposed to bring that side of the pelvis down, correct? Which is prevented by the gluteus muscle. So it does not allow that hip to go down with gravity. Okay. Now, because this gluteus is weak, it is not able to prevent it. So that is why each time one foot is in the swing phase, the pelvis dips down due to gravity. So that's why down this side, down that side, down this side, down that side. That is what is causing a waddling gait.
I stand on this leg and if I lift like that, my pelvis should go down on the right side. It does not. In fact, it goes up because this gluteus muscle contracts, preventing it from going down. Otherwise, I wouldn't have been able to maintain the balance. Now, because this muscle is weak, when I do that, this dips. And when I do that, it dips. And therefore, you get a waddling gait. What happens in dislocation? Does the same thing happen?
Dislocation of the hip is a painful procedure. Means we are talking which dislocation? Acquired or congenital? Develop. So the acetabulum is not in the socket, it is pushed out. So that leads to atrophy of the muscle and therefore the same thing, right? The muscle is weak and that is why. Fine.
On examination, the child is conscious, alert,
Just tell us if there's anything positive.
and otherwise the child is normal. Head to toe, the child had normal feces. However, the child had exaggerated lumbar lordosis and bilateral calf muscle hypertrophy. Oral cavity was normal. CNS wise, the cranial nerves are not involved. In motor system, the gait was waddling gait. Slight toe walking was present. Ankle contractures were present. Power in the upper limb. In the neck, the flexor is 2 by 5 and the extensors. The neck muscles were actually involved and the other muscles of the upper limb were not involved. Hand grip was strong. Lower limb in the hip, the flexion and the extension, the hip muscles had a power of 2 by 5, whereas knee and ankle had a power of 3 by 5. Percussion myotonia was not present. Reflexes, all the reflexes were 1 plus, except ankle, which was 2 plus. Plantars were upgoing. Superficial reflexes were present. No abnormal movements present. Meningeal signs were absent. No cerebellar signs were present. Sensory system was intact. Per abdomen, soft, non-tender, no organomegaly. RS-wise, nothing. CVS also, no murmur present. Diagnosis, a 9-year-old girl.
So you've done any investigation?
Yes, so actually, this child has been evaluated in Bhopal only. Recent investigations may everything in the blood is normal, whereas There she had done CPK, which is 9,480. But the MLA has not detected anything. No deletion or duplication of genes has been detected. They have also done an EMG at that time, which was normal. They have also done an MRI of both the lower limbs. That is also normal. So spine they have not done.
So now what?
We'll have to find alternative causes.
Autosomal cause, other muscular dystrophy, limb girdle muscular dystrophy,
So that will show in whole
whole
exam.
exon.
Muscle biopsy will only tell you dystrophy. It will not tell you the cause, right?
Thank you.
Thank you. Online audience, any questions or any comments? Anjali, anybody else?
Rajesh, hello. Hello.
Yeah, come in.
Rajesh, he mentioned planters outgoing. In the finding, she mentioned planters outgoing. Just recheck.
Mahesh, your voice is not clear. Thoda speak away from the mic.
She
He
she she
says
mentioned she mentioned planters outgoing. I
No,
have
no,
put it in the chat.
that
Just
was a
just check.
withdrawal. They were testing with a very pointed stimulus, so it was a withdrawal reflex.
Okay. She mentioned outgoing, so I was a bit surprised.
Yeah,
That's not fitting in this. Yeah.
yeah,
Okay.
Rajesh. In the first case, was it too early a presentation for inflammatory bowel disease at 2 years?
Yeah, it is early, but nowadays we are seeing and talking about IBD coming in young children also. So to that extent, it's not unheard of, but yes, it is early.
Also, in the second case, should they have done a TSH?
In the second one,
Yeah, for debris amylin.
Yeah.
so
Cautious
there are no other features of hypothyroidism in the girl. She is looking quite normal otherwise.
Only
But
because
Rajesh,
it's
this
a
is usually.
treatable cause.
No. Anjali, what
Yeah.
you said is right. Because in this cautious debris, you may not have any other feature. This being an acquired one, they are in fact more intelligent people because they are sitting and doing their job all along. So they will rank and everything will be numbers and everything will be good. And definitely, I agree with you, Anjali.
Okay.
But, yeah.
ESH,
SPL.
do it, yeah. Anything else?
Rajesh, we miss seeing the faculty.
Sorry?
We miss seeing the faculty. That's it. Thank you very much, Dr. Amdekar,
Okay.
Rajesh, and all
Thank you.
other faculty.
Thank you. Thank you.
And
Bye.
all the students for having done so well.
Thank you. Thank you. Bye.
Bye.